Let's talk about the relevant anatomy for neuraxial anesthesia. Now, as you understand that we are talking about the neural axis. Now, neural axis consists of the spinal cord, which is encased in the vertebral column, right? So if you look at this diagram, you can see that in the core we have the spinal cord, and as you go outside we have structures, and outermost are the vertebrae. So we will talk about each structure as it goes from core to the periphery. Okay, so in the center we have the spinal cord. Now first let's talk about spinal cord. Spinal cord is the continuation of the brain stem, right, into the vertebral canal. So it begins at the foramen magnum and it terminates at L1 in adults and L3 in infants. And when it terminates, it has two extensions. One is the neural extension, that is the nerves. They form a bunch, and that bunch is called the cauda equina. And all the fibrous structure also extend, and that fibrous extension is in the form of phylum terminale, right? Now if we move further out, look at, okay, this I'll explain this. Look at this diagram. Right, so we have the spinal cord in the core, and outside the spinal cord we have the meninges, and these meninges are continuing from the brain. So what are those meninges? If this is the spinal cord, the one investing it very closely is the pia mater. Outside this is the arachnoid matter, and further out is the dura mater. Outside this dura mater we will have our vertebrae. So you see, this is the spinal cord and it has its meninges. The roots are coming out, and even these roots have these coverings. This is the dura, the outermost meningeal layer, and outside this we finally have the bony structure, which is the vertebral column. Now remember this cross section. Okay, now the pia mater, which closely invests the spinal cord, is highly vascular. Outside pia mater we have the arachnoid matter, and in between them is the subarachnoid space, which contains the CSF. Now this subarachnoid space extends up to the cranium. It enters the brain as well. So anything in the CSF can reach the brain. Outside the arachnoid we have dura, and yes, arachnoid is not vascular and it is a very tough layer, and as in the brain it is the major barrier to drugs. So if we want any drugs to reach the spinal cord, nerves, and even the brain and enter the CSF, we have to pierce the arachnoid. Outside arachnoid is the dura, and obviously in between them will be the subdural space, but this subdural space is very small. Now this arachnoid and dura are actually very closely adhered to each other, such that when we want to enter CSF, although it is the arachnoid that is to be pierced, but we only talk of dura because dura is tougher, and when we cross dura, when we pierce dura, we actually pierce dura and arachnoid together. Now dura is the one that extends up till the S2. When I say dura, basically the meningeal sac, the whole meningeal sac that extends up to S2. Here it is very clearly shown. This is S2, this is L1. The adult cord ends at this level. If this is L1, this is L2, this is L3, this is where your infant cord would end, right? Although the main spinal cord has ended, the fibrous extension you can see continues, and that's the phylum terminale here. And the coverings of the spinal cord, obviously the pia will end with the nerves and the spinal cord. The rest of it, which is dura and arachnoid, but we call it, you see here it is mentioned dura arachnoid, we call this sac as the dural sac itself because they are closely adhered to each other. Why I am mentioning this again and again is because CSF is present in subarachnoid space. But this subarachnoid space means this is bound by arachnoid, but for practical purposes, we consider it is bound by the dura arachnoid. So if we say the dural sac ends at S2, we mean that dura arachnoid actually terminates at S2, which means that CSF is available up till S2. Where this is important is that the main chunk of the spinal cord in adults, it ends at L1, right? But the CSF is present up till S2. So this is the part where we have CSF but no spinal cord. So this becomes a safe space for any intrathecal injection maneuvers or any procedure that we need to do. Where we exploit this is usually when the conventional approach is usually lumbar, right? We do a lumbar puncture, but there is one sacral approach as well. That's the Taylor's approach. I'll talk about this in the video where I have catered to the technique and a lot of other things, but majorly where I talked of technique of spinal anesthesia. So this Taylor's approach requires us to pierce the dural sac somewhere here in the S2, and the landmark for it is posterior superior iliac spine. Like for lumbar puncture, the landmark is the Tuffier's line, which is the L3, L4 space, right? But for Taylor's approach, we go way beyond in the sacral vertebral column, and that's where we reach the CSF. So if we can reach CSF anywhere between like below L1 to up to S2. Okay, so let's talk of outside dura. What happens outside dura? Where is it? Okay, so yes, this is the spinal cord, this is the dura, this green one is the dura, right? Now outside dura, what do we have? We have the vertebral column, but before vertebral column we have a potential space, which is the epidural space. So let's talk about this space here. Outside sorry, I'm so sorry. We have the vertebrae here, right? Vertebrae and other stuff. So outside dura, this is the epidural space. Now epidural space is a circumferential space outside of dura, but it has its relations. This is anterior, like ventral, this is anterior, this is posterior or dorsal. So anteriorly you have the posterior longitudinal ligament. Outside this is the vertebral body that is shown here. Okay, posteriorly you have the ligamentum flavum, and on the lateral side, on the sides, you have the pedicles and the intervertebral foramina. There must be one more diagram. Yes, okay, this one. So we have this yellow thing is the spinal cord. Okay, then this green one is the dura. This is the spinal cord. This is the dura, and outside dura, this is the epidural space. See, so epidural space. Now this is anterior and this is posterior. So as you go posteriorly, you will find the ligamentum flavum. See this part here, this what it has shown. So posteriorly in the epidural space is bound by the ligamentum flavum. Outside the ligamentum flavum we have the interspinous ligament, and then we have the subcutaneous tissue. Now anteriorly as we go, anteriorly we will have the posterior longitudinal ligament, And outside that we have the vertebral body, outside which there will be anterior longitudinal ligament. Okay, so these form the anterior elements of the vertebral column, the body and the body and the anterior longitudinal ligament. So epidural space, if you understand by this diagram, posteriorly is bound by the ligamentum flavum and anteriorly it has the posterior longitudinal ligament. This is the immediate relations. And laterally, as you could see in this diagram, laterally you will have the pedicles. So this is about the boundaries of or relations of the epidural space. Next comes its contents. The contents of epidural space contains, obviously there will be nerve roots, then there is fat, there are lymphatics, and then there are blood vessels. Of the blood vessels, there is a venous plexus which deserves mention. That's the Patson's venous plexus, and it contributes as an important part of venous drainage. Now, epidural space, some few points about it to remember are that it is a segmented space. This is in comparison to the subarachnoid space. Okay, so you understand when I'm talking about subarachnoid space, I'm basically comparing the anatomical relevance of the spinal versus the epidural. Okay, so epidural space is segmented space, which is because of there are certain septae or some tissues, some fibrous tissues will be there, and hence it is not very uniform. Not uniform in comparison to the different types of vertebra, like lumbar and thoracic have their own differences, and within the lumbar itself there could be differences, right? And this hence if affects your drug spread. Subarachnoid space is much more uniform, and unless there is a pathology, it is not really segmented. The CSF, it extends up to the basal cisterns of the brain, right? That means it can go intracranial, whereas the epidural space, it does not reach inside the brain. Why? Because of this ligamentum flavum. Now let's talk a little bit about this ligamentum flavum, which forms an important anatomical structure for us. Ligamentum flavum, it extends from superiorly from the foramen magnum, inferiorly to the sacral hiatus. So because of ligamentum flavum, the epidural space is not able to go beyond the foramen magnum. So it basically any drug that I have given in epidural space, there are less chances unless the drug has diffused through it has if it will diffuse through the dura into these dura and orechinol into the CSF and basically becomes intrathecal, and that ascends up along with CSF. Other than that, any drug that any substance in the epidural space should not reach inside the cranium in substantial concentrations. So that's why ligamentum flavum is important. The another part thing about it is that it is also not uniform. Rather, its uniformity varies in within one intervertebral space itself. It is composed of actually two two ligaments. At each level, there is right and left, and then these two join in the middle, and they form a ventral opening. And why is it called ligamentum flavum? Because flavum means yellow. So on dissections, it was seen to be a yellowish colored structure. I'll show you. It's there. It is. Okay, so ligamentum flavum is, see, it's outside, and it is made of two, the left and the right, which join in the middle, and then we have this opening which is ventral. Okay, so outside ligamentum flavum, we have the interspinous ligament, or where there is the spine of the vertebral column, the vertebrae itself, and outside the interspinous ligament there would be the subcutaneous tissue. Now, couple of things about the vertebral canal itself. We know that the vertebral canal has uh, 33 vertebrae in all, and we have 7 cervical, 12 thoracic, 5 lumbar. We have 1 sacrum, which is actually fused of 5 sacral vertebrae, and then we have a coccyx. Okay, so each vertebrae can be divided into 2 parts, the anterior elements and the posterior elements. The vertebral body makes the anterior element, and rest of it, the spinous process, the transverse process, the lamina, the pedicles, they all form the posterior ligaments. The posterior elements. And talking of the spinous process of the thoracic are more slanted, they are more oblique or angulated caudad, okay, as compared to lumbar. Lumbar are more horizontally angulated, and this makes a difference when we are approaching the thoracic epidural space. Now let's talk about the blood supply of vertebral column. Okay, so it's made of anterior spinal and posterior spinal arteries. Then there are some segmental arteries. Okay, so anterior spinal artery is single, posterior spinal artery are two, and segmental arteries, obviously they are many. And the anterior spinal artery comes from the vertebral artery. Okay, so there are branches from the vertebral artery of both the sides that join in the middle, and they form the anterior spinal artery. So this comes from the vertebral artery, its origin. And posterior spinal artery, its origin is from the inferior cerebellar artery from both the sides. Two, like one from each side, emerge and supplies the posterior part of the spinal cord. Then segmental arteries, they come from the intercostal arteries and the lumbar arteries. These segmental arteries enter the spinal cord through the intervertebral foramina. The anterior spinal artery supplies the anterior 2/3 of the spinal cord, and posterior spinal artery would supply the posterior 1/3. But the medullary branches, when I say medullary branches, means if this is my spinal cord, this is the gray matter, okay, right? So if this is the anterior spinal artery, it will give some branches that will pierce and enter the core and reach the gray matter in the core. So these are the medullary arteries. The medullary branches from the anterior spinal artery are far less as compared to those in the posterior spinal artery. Hence what happens is, see here, we have a single anterior spinal artery and we have two posterior spinal arteries, and these are the medullary branches. These medullary branches supply the innermost structures of the spinal cord, and since anterior spinal arteries medullary branches are few, the area supplied by the anterior spinal artery becomes more prone to ischemia, which is what? It is the gray matter, right? The gray matter, which is in the most center of the spinal cord and supplied by the anterior spinal artery, that becomes the most prone to ischemia. And if ischemia of this happens, it's called the anterior spinal syndrome. Okay, talking of the most prone to ischemia structures of the whole spinal cord, the mid thoracic segments, which are T3 to T9, these are the most prone, again because they have fewer, the segmental arteries, the medullary branches are fewer for um, these levels. But at any level, if you have to compare, then at any level the gray matter is most prone for ischemia. The venous drainage follows the arterial supply, and we have 3 longitudinal anterior spinal veins, and we have 3 posterior spinal veins. These communicate with the segmental anterior and the posterior radicular veins. Okay, finally draining into the vertebral venous plexus, which is present in the medial and the lateral compartment. Okay, and in the it's present in the epidural space, right? There are no veins in the post epidural space except for in the L5 and S1. Okay, so now if you see this diagram,